Okay. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Zaleha and Dr. Zimi. Right. Thanks for inviting me again for UI. I put as UITM BCS series, something like that. Right. Okay. So I'm asked by Zingwi to give 2 sessions for sample size determination, right? So based on study designs, definitely I cannot cover sample size determination by only 1 session, right? I need to do at least 2. But for your information, sample size determination it is a very what you call the broad topic, very what you call broad topic with a lot of contents. So I used to run workshop together with my wife, Dr. Wanarpa, at what you call Institute of Medical Research around 4 days. We did nothing but sample size determination, right? We tried to discuss about sample size determination for so many types of studies. So we run around 4 days workshop. So for me, for if I as I'm given around 2 hours each for 2 sessions, I can cover only fundamental which you call the concept and application of sample size determination, right? Very basic and fundamental things everybody should know, right? That one I can cover for 2 hours today, and on the 15th another 2 hours. However, there are some more specialized topics for sample size determination. That one definitely I cannot cover. For those who have different what you call the study designs and different concept of sample size determination, please contact me after these 2 sessions. If the topics I cover are not, not the one that you want, please contact me. I will try to answer. Right. However, for public health personnel and also clinicians and majority of laboratory-based medicine people, my topics that I'm going to cover for 2 days are quite adequate, right? As I mentioned, there are some more specialized topics, especially for laboratory-based medicine. Please contact me, right? And then I can also for public health, right? Clinical part, quite straightforward. I think clinicians, if you can understand these 2 sessions, I think more than enough, except some specialized topic, like for example, survival data analysis. I cannot cover survival data analysis here for 2 days. So for clinicians, many clinicians ask me after my sessions, they want to know about how to calculate survival data analysis. I need different session for them. Survival data analysis also is a quite a large contents that I need to cover for clinicians. So let me know for clinicians if you want to know more about some determination for survivor data analysis, survivor time data analysis. Let me know. I have to cover separately, right? Time definitely not enough, right? Okay. So my plan for these 2 sessions is I have around 4 components, right, to cover. First component is I need to explain you about concept of sample size determination and basic fundamental things I need to explain back. Many of you or all of you have learned before, but you may have forgotten, right? Forgetting is normal, right? Especially in statistics, quite easy to forget. So first component of my my session 2 sessions, first component is I need to revisit with you together what are the fundamental things that you need to know when you are thinking about determining a sample size, right? You can ask the statisticians or epidemiologists to calculate sample size, but if you don't know the fundamental basic things, you are at a loss. And my intention is, I always intend that after my sessions, you may be a clinician or public health personnel or laboratory-based medicine lecturer or postgraduate student. I want you to be independent researcher, right? After my sessions, you know how to calculate by yourself. You don't need to look for a statistician or epidemiologist anymore for those particular topics that I have covered. You can check back with them, but I want all of you to determine the sample size by yourself, right? By yourself, and you counter check back with those who are familiar. I want you to be independent researchers where you know how to calculate sample size by yourself. And statistical analysis is the same thing. After my sessions, you know how to analyze by yourself, right? And you counter check back. Uh, uh, Otherwise, spending time, right, like these lectures and following the sessions is meaningless if you don't become an independent person, right? So that is the first component I'm going to cover, the fundamental things. Second component is, as I've discussed with Dr. Zimwi, I'm going to cover for experimental studies, right? Experimental study in the sense, mainly for interventional studies, right? So interventional studies, I'm going to touch on clinical trials, different types of clinical trials. And the second part is I'm going to touch on community trials. The concepts are similar, but there are differences. And the last one is animal-based studies where intervention is involved, right? So these three parts I will touch, but animal-based studies, I will touch on mainly on the theoretical part because basically animal-based studies, they go for animatics, right? Animal ethics, right? So I'm sharing you got the human research ethics in UNISA. So many I handle for human research ethics. Animal ethics go to another committee. However, sample size calculation principle is the same. So I'm going to highlight what are the important things for animal-based studies, how to calculate sample size. So that is my second component. So first and second component, I'm going to finish by today, right? Inshallah, I'm going to finish by today. Fundamental things I explain. And second part is I'm going to demonstrate, I'm going to tell you basic concept and the demonstration for experimental studies. And the third component, that will be on 15. Third component is observational studies. Observational studies have two parts. One is descriptive observational. Second one is the analytical observational. So both I will cover. There is a bit heavy session for 15. The descriptive observational, analytical observational. That is the third component. Fourth component is I'm going to have tests for you. The test is, I have a habit that I always have assessment for my sessions, right? How much you understand. So maybe I will do tests today also if I have time for experimental study. If I don't have time, I will do on 15. The test will cover which was some exercises for you to do straight away, right? Straight away, you have to turn on your computer with software on, and you are going to determine your sample size where I show you the questions. You straight away do the sample size calculation by software, right? So that is my fourth component, right? So these four components, I hope inshallah with 2 sessions I can finish, but to be honest with you, a bit cramped and a bit rushing because of the time. Normally for students, for those who are my ex-students, they know sample size calculation, I teach 1 or 2 weeks, right? For them to understand. So now I'm given around 4 hours, 2 hours each for 2 sessions. So I'll try my best, right? Fundamental things I cover and for your understanding. And please stop me anytime if you are not clear. Stop me anytime. I will explain you till you understand, right? Okay. So we are going to talk about determination of sample size in medical health sciences research. Basically, principles are the same, right? So that's why I combine together medical health sciences research. So sample size is just a guide. We, as medical statisticians, we try to help researchers to get minimum required sample size, right, to be scientifically and statistically sound. The study must be scientifically sound, statistically sound. Then that can be that result can be inferred back with both internal and external validity. As we all know, we need to have both. We need to fulfill both internal and external validity of the study. For that, especially for internal validity, started the methodology must be right. One of the key points for methodology is sample size, right? We are not so much fussy about numbers. We are just helping the researcher. And I just want to tell you, I myself, I categorize the sample size calculation as 3 categories, right? Number 1 is compulsory to calculate, right? First category, your sample size calculation is compulsory, right? When are you going to calculate sample size as compulsory? Whenever there is a testable hypothesis. When you have your study is with testable hypothesis or hypotheses, more than one, you are supposed to determine your sample size since proposal presentation time, proposal development time, right? So that is must, right? So majority of us, our lecturers, our postgraduate students, there are testable hypotheses, right? There is a significant difference of mean height between boys and girls. There is an association between smoking and heart disease. All testable hypotheses, you are supposed to calculate sample size. Second category is unnecessary. Unnecessary means your sample size calculation may be unnecessary, right? For example, especially like animal-based studies or bioequivalent studies, right? Some types of studies, they have their guidelines, national guidelines, international guidelines, right? So we just follow the guidelines, then fulfill the requirements, right? However, these guidelines, how do they do it? For example, some bioequivalent studies, they start with, let's say, albino rats 6, 12, 18, 24, 30 per group, and so and so. How do we get it? That guidelines, we have to see back whether it is scientifically and statistically sound or not. So if there are guidelines there, you may follow, or if you don't want to follow, if you have literature support, then no problem, we calculate as it is. We are going to calculate sample size by using many ways, right? So that is, I put as unnecessary, right? But sometimes, as I mentioned, when I was at USM, for animal-based, committee, animal ethics committee, they always ask the applicant to go back and determine the sample size, asking statistician, even though there is an animal-based study, right? So there is a gray area, but if you go and look at the website, some universities mention very clearly for animal-based studies, right? Third category is no clue, no way to calculate. For example, some people work on cell lines. Cell lines, one cell line includes thousands or millions of cells. So if you want to work on cell line, for example, some biomaterial, right? Either it is a living or non-living, the material, if you are going to use it. And especially for living with cell line, how are you going to calculate sample size, right? It is no way, right, impossible to calculate sample size, right? So you ask yourself, your study falls under which category, right? That is the category that I used to mention to Human Research Ethics Committee of USM when I was in USM. I explained to them, right? But majority of applications to Research and Ethics Committee falls under first category, right? Because they are testable hypotheses, right? Okay, so sample size determination is depending on study design and available information from literature, right? You need to go back to your fundamental study design knowledge and which study designs I'm going to use, right? And based on that, we calculate sample size. And of course, literature support is very important, right? So literature, I just want to remind all of you, many people go for literature, and now these days very good to go in Scopus, the WOS, or any other databases, even PubMed and even Google Scholar, right? However, my suggestion to all of you is that which one is the best literature for you to calculate sample size, for you to go for your writing proposal and so on. So there are three categories, as you know: local, regional, global, right? The best is actually local, right? However, it must be peer review. It must be published in peer review journal, index, right? Then that literature is very good for local literature. If you want to do a study in Malaysian population, of course, Malaysian context, the literature from Malaysian context is the best, right? If you cannot get, then go to regional, around here, Singapore, Thailand, Indonesia, Philippines, and then go for China, India, Korea, Japan, and so on. If cannot get, then you go for global. The danger is if you go straight to global, the danger is sometimes when you calculate want to sample size, the parameters you got from literature for the from countries like, for example, US, UK, Europe, and Australia, so and so, sometimes not applicable to our context, the Asian context. Then when you calculate sample size may not be applicable to our context. So my suggestion to all of you is first go for local, right? Now these are also many Malaysian journals are indexed, right? So last time, 25 years ago, right, only 2, 3 to maximum 5 journals, Malaysian journals are indexed, right? Now there are many. So important, right? And then another important thing is quality or strength of statistical inference depends largely on size of the sample selected. So you want to infer whenever you do your study, as you know the statistical principle, statistical inference, inferential studies, you want to infer your sample to population, right? At that time, if the sample size is inadequate, right, you may end up with the results which cannot be inferred by the population parameter, right? So sample size is a key issue, right? Whenever applicable, right? The question is, do I need to calculate sample size for every single study? My answer is very simple. Depends. Go back to 3 categories that I give you. Ask yourself, right? And then decide, right? If you submit your proposal, your postgraduate students, your own proposal to research committee, ethics committee, the funding bodies, right? In clinicians, definitely you need to determine sample size for randomized control trial and so and so. If there is no, your proposal will not be entertained by the funding bodies, right? If you have experience of looking at international, multinational, multi-centered research proposals for clinical trials, for example, you will see it. Sample size determination alone may be written around 5, 6, 7 pages, right? Sampling alone or randomization alone may be around like that, 4, 5 pages, right? So these are the ones that fundamental things, right? I used to see many application for ethics approval from many pharmaceutical companies like Novo Nordisk, Bayer, Eli Lilly, right? And so, Abbott. We found there are centralized statisticians. They wrote very detailed methodology. And one of them is sample size determination. So we cannot underestimate for the reviewers. Some reviewers are very knowledgeable, right? Some clinicians are very good in methodology and statistics, right? So we cannot underestimate, right? Okay. Another thing I want to touch and go is study design. I'm sure many of you have learned before. However, you may have forgotten. I want to give you relatively up-to-date classification of study designs. The 4 study designs in our medical health sciences research. First is by hierarchy, top to bottom. Top is best, bottom is the least, right? So first is systematic review and meta-analysis. These days, you cannot run away from this, right? Systematic review and meta-analysis. Second is interventional studies. Some people call experimental studies, mainly for clinical trials and community trials. I will touch on it, both of them today, right? For my second component, right? Third one is observational analytical studies, PC. What are they? Cohort, case control, cross-sectional. This part will be covered on 15th of this month, right? And then the last one is observational descriptive studies. I think all of us know. Prevalence incidence studies for population, case report and case series for individuals. If you look at it here, because of the time, I may not be able to cover systematic review meta-analysis. If you want to talk about it separately, we have to talk about it. Other three I will cover, right? Interventional studies, definitely you need to calculate sample size, clinical trial, community trial, detail, you need it. Observational study, observational analytical. What is the difference? Observational analytical means you are going to analyze based on the testable hypothesis. You are going to analyze detailed, very heavy statistical analysis for observational analytical studies. Observational descriptive means just describe, right? Like prevalence incidence studies is a descriptive study, observational studies for population. So for observational analytical studies, 3C, cohort, case control, cross-sectional, very, very much involvement of sample size calculation, same as to clinical trials, community trials. In observational studies, population prevalence in the study, definitely you need to calculate sample size. Only individual case report case series, of course, sample size calculation is not applicable for the case report case series. So basically, if you look at it here, you are supposed to understand the sample size calculation concept and application for clinical and community trials and observational studies for analytical and descriptive. So I will try to cover as much as I can. Of course, there are many added study designs where many people are not familiar with, then I cannot cover for the time being now, right? Okay, so I will come back to one by one. So just for you to remember, in other words, if you look at this diagram, right? I think many people know about this diagram, this pyramid, right? We go these days based on evidence. We cannot run away from evidence-based practice, right? People last time called evidence-based medicine. Now we call it evidence-based practice. Evidence based on evidence, study designs, top is the best, bottom is the least, right? And it has filtered information and unfiltered information divided into two categories, right? What do you mean by filter and unfilter? Filter means publish already and you are going to criticize, do the critical appraisal, and you are going to summarize them. There's a filtered information. Unfiltered means newly developed protocol and newly published article with newly developed protocol. That is called unfiltered information. Unfiltered information started from background information, expert opinion, considered the beginning of the research, case control studies, case series, report, cohort study, till randomized control trial. As we all know, right, randomized control trials are considered as gold standard. What is gold standard in our research? Gold standard means most reliable method. Right? So even though RCT is considered as gold standard, it's still unfiltered information. So these definitely you need to calculate sample size. And next level filter is we start from critically appraised individual articles, right? Critically appraised topics till systematic review, right? These critically appraised topics and individual articles are actually basically statistical synthesis that is called meta-analysis. So basically systematic review and meta-analysis are at the top. So these days, if you want to do a study, if you want to do a trial, write a 3 or 4 pages, the concept paper, right? Don't write full proposal yet, and send to Cochrane Center. Ask whether that particular your trial, either in community trial or clinical trial, is whether it is done or not, already done or not, and they will answer within 48 to 72 hours, right? And they will say, proceed. Your study that nobody has done, or don't do it, people have done, and so on, right? So these days we don't waste time. We go to Cochrane Center, and we are going to look at it whether it is worth it. We do a trial, right? So that is the thing, we need to know it. For the time now, Cochrane does not support observational studies, as far as I know, right? So if you want to do observational study, you can do by yourself, right? You can, but you have to look for it by yourself, right? So what I mean is, these days, especially for trial, right, you go and see what is done, what is already done in what you call it, the literature by contacting Cochrane Center and so and so. Then, if not done, you proceed with your proposal, right? So these are the ones that, with regard to sample size determination, we are supposed to determine sample size, right? Okay. So let me do study design here now. Sorry, the sample size calculation now. Just for your information, this is my own flow chart for teaching, make it easy for everybody, right? So we have descriptive, observational, experimental. Based on that just now, I've shown you the classification. Observational, analytical, observational, descriptive, and experimental, right? So here you need to know some statistical jargons, right, and formula, right? Don't be afraid of formula, right? Formula I will introduce, but at the end of the day, we calculate by software, right? But without understanding formula, you don't appreciate much. So I will explain first, and then I will go for software. By using software, I will go for sample size calculation, right? Okay. In descriptive, you may have a cross-sectional study or prospective cohort study, right? Then in cross-sectional, mostly we do single mean or single proportion, mean and proportion. Basically, mean and proportion, right? So we calculate it by single mean population or single proportion single mean formula or single proportion formula, and prospective goes for single proportion and so on, right? So this is actually very useful, especially single proportion. Single mean is not very common, right? Even the next week coming, I'm not going to focus much on single mean, but single proportion is very, very common, right? For example, you are going to determine the prevalence of smoking among female adolescents in Malaysia, right? Then you are going to know you must know the sample size where you are going to collect the data. So then you can use the single proportion formula, for example. And then the observational study, analytical, you have prospective cohort, retrospective cohort, case control, cross-sectional, right? Then you are going to use proportions. Majority of us, we use proportion. Why proportion? I will come to that after this, right? So proportion, for example, prospective cohort, you are going to look at the disease among exposed group versus disease among non-exposed group. Then you are going to calculate sample size to proportion. In retrospective cohort, case control cohort study, exposure among disease and exposure among non-disease, right? I will come to that, don't worry, right? So basically, you are going to do two proportion, maybe an independent and related sample. I will come to that also. And not very rarely, but not very common, is two means formula for observational analytical studies, right? So basically, we all know, in descriptive studies, incidence prevalence is just the single mean or single proportion. In observational studies, analytical, more than or equal to means, or more than or equal to two proportions, right? So on the way, I will explain. Don't worry, you will understand it. What is mean? What is proportion? Mean, right? The numerical average. Proportion mean come from percentage, right? So for that, when we calculate sample size, you will be clear, right? The last one is experimental studies. You may do a parallel design. You may do a crossover design, right? So then you may do independent means or independent proportion, related means or related proportion. Depends on that, right? So don't worry about that. I have some tips for you to learn. Based on tips, you can calculate sample size, right? So just generally, if you understand, right? So I have a plan to touch and go back study designs for your revision, right? Otherwise, when I calculate sample size, cohort, case control, so some may be familiar, some may have forgotten, right? So for that, I'm going to touch and go study design, revision, right? Revisiting, right? So understand this, sample size determination is very much depending on study designs, right? And very much depending on mean or proportion, either single mean or single proportion, or two means or two proportion, or related sample or so and so. Don't worry. After that, I give you tips how to go for sample size calculation, right? Okay, let me just go. If you have questions, please stop me on the way anytime, right? First, with experimental studies like randomized control trial. Remember, you have a research design, research question. Research design is randomized control trial. Research question is effectiveness of new anti-appendicid drug, for example. So there are many to the trial, the methodology, many methods, but I'm going to touch only on two, that is parallel design and crossover design. So parallel design is, you have your parallel, you got from the population, you got the sample, randomize them. Don't forget, you need to randomize them, right? In interventional study, randomization is the key, right? Especially for clinical, right? Randomize them, and you got a test, you got a control. In other words, you have your new, for example, you have new drug and usual drug. You are interested in looking for the difference of blood pressure reduction between new and usual drug, new and old drug. So what will be your key point you are going to think about? Number one, what is the study design? Study design is, it's a randomized control trial. Is it right? And number two, you are going to look for the mean difference or proportion, right? This is the mean difference, right? Pre and post treatment difference of mean blood pressure in new drug, pre and post difference of mean blood pressure in usual drug, and you compare. You're going to compare by two means, right? So what do you mean two means? Mean difference of blood pressure reduction, mean blood pressure reduction in new drug, mean blood pressure reduction in usual drug. Compare, put in the two means formula, calculate sample size. You got a per group, right? Let's say 100 mean 100 per group, 100 for new drug, 100 for usual drug. So that is the concept of parallel design. Parallel design is crossover design. Many clinicians know about it. Crossover design. What is the crossover design? Crossover design is look at the randomize them. First round is test and control drug. One group, one arm. We call it arm, right? One arm will receive test drug. Another one will receive control drug. Next round, control and test crossover. First group the first group of patients who got test drug will be receiving next round control drug, and the other side is control first and test later. So this is called crossover design. What is the purpose of doing crossover design? In many diseases, especially rare condition, rare disease or new disease, sample size is inadequate. If you go with parallel design, where here design where is a very favored study design of clinicians for parallel design. Many clinicians they are in favor of parallel design because it is much easier to do, right? Much easier to perform. Statistical analysis is straightforward and so on. They go for parallel design. So if you look at in the high power impact factor journal, you can still see simple parallel design, right? The accepted papers, right? However, some situation, sample size is inadequate, you may have to go for crossover design. The big advantage of crossover design is you don't need a sample size as big as parallel design. You can cut down the sample size approximately by half, right? Because they are using test and control and test. However, you have to be very, very aware that sample size calculation for parallel and crossover is different. Parallel is based on independent sample, where in crossover is for related sample. Related sample means same sample. If you look at it here, test and control and test. If you calculate sample size by using independent sample, we are wrong. Why? Because they are not independent sample. They are, if you look at here, they are same sample in one arm, right? So community trial, clinical trial, many people calculate wrongly by using independent sample, right? Para should be related, right? So that is the what you call crossover design. Crossover design, of course, I'm not going to go detail about crossover design because this session purpose is for sample size calculation. However, just to touch on that, crossover design, where are you going to use? Crossover design, what you call the design. As we all know, crossover design has some disadvantages, right? What are they? Statistical analysis is complicated. Need to plan very well. You need a medical statistician in the group, and then you need a washout period for those which are having how do you call it, carryover effect, right? I think many people are word of carryover effect. A carryover effect means from the new first round drug may still remain in the body, right? When you second round drug, first round drug and second round drug may interact, right? Because of the long plasma half-life, right? So because of that carryover effect, you need a washout period, right? And statistical analysis is complicated, right? And the sample size calculation is definitely complicated, right? So if you have crossover design, you are planning to do that, don't forget to include, don't forget to recruit an experienced medical statistician, right? Not every statistician are familiar with crossover design. So for those who are familiar with the crossover design, especially working in medical school, medical faculty, those statisticians are familiar. So you can recruit them as your the co-researchers, right? So basically, crossover design sample size is around more or less around half of the parallel design, right? So that is experimental studies, right? Just to touch on community trials. Community trials are very similar, right? Very similar to you got the clinical trials. However, the difference is, all know, comparison between community and clinical trial is community trial measures exposure and outcome under less well-controlled conditions, whereas in clinical trials with the most strict conditions, right? So in clinical community trial differences, even in clinical trials, in the health setting with a strict atmosphere, right? And then they measure efficacy of the drug, as you know, for the four phases of clinical trial, as you know, right? So the phase three is phase of clinical trial for that is for efficacy, right? And after they do the phase 4 post marketing survey, right? PMS. So clinical trials are in a stringent condition, whereas the community trials are measuring effectiveness, right? Effectiveness and unit of measurement in whole communities. This individual, right? Question asked is in the real world in community trial, where in the clinical trial is phase 3 is for mainly in the the stringent condition. Phase 4 measuring the efficacy, whereas in phase 4 is for post marketing survey, where looking at whether the drug really works in the real world, right? So what I mean is community clinical trials, the way of thinking for sample size calculation is the same. However, there are many different things. For example, in clinical trial, by right, use randomization, right? Randomization. So based on randomization, randomized control trial, randomized placebo trial, and you are going to calculate sample size based on many factors, calculate sample size based on randomization, randomized group. Whereas in community trials, sometimes you cannot do randomization, right? It is impossible to do randomization. So in that case, you run the non-randomized community trial known as Quasi experimental study. I think many of you are familiar. QASI, Quasi, right? Quasi experimental study. The meaning of Quasi experimental study is this is a non-randomized control trial, right? And you may end up with randomization. End up with no randomization. You may have to do it purposively, right? You have to do it. For example, some communities you may choose the the communities as intervention and control for community trials. Purposely. This particular community is well cooperated. They may be chosen as intervention. Another one which is a bit far apart from the apart from the other community, you may choose as control and so on, right? So randomization is not the key issue in quasi experimental studies, right? Not the key issue. Key issue is intervention, right? If you look at in the community trial methodology, randomization is not the key issue. But whereas in clinical trial, randomization is the key issue, right? So come back to sample size calculation, right? You may do a clinical trial. You may do a, let's say, weight reduction program. You may have 4 arms. Arm 1 is diet control. Arm 2 is diet control plus aerobic. Arm 3 is diet control and aerobic and health education. Arm 4 is control group, for example, right? So you are going to calculate sample size. You have 4 groups, so you look for the difference among groups, right? After that, I will show you, right, how to calculate. So your outcome is you are measuring something, for example, weight reduction, mean weight reduction, right? Continuous variable, right? So you are going to compare among 4. So how to calculate sample size? You are going to compare, let's say A, B, C, D, 4 groups. So A and B, A and C, A and D, B and C, B and D, and so on. So you try to get from literature, you calculate. Sometimes from literature not available. Then whatever you can get it, you calculate and take the biggest one, multiply by 4. Why multiply by 4? Sample sizes, where the groups are 4 groups, right? So there you need to do a number of calculations sample size. No need to do by hand. You can use your software. So conclusion, clinical trial, community trial, the way of calculating sample size more or less the same. However, there are some special cases to think about. For example, we got the crossover design, right? For example, let's say you are looking for the clinical trials where you have more than 2 arms, right? So you have arm 1, 2, 3, 4, and crossover. Crossover, arm 1, 2, 3, 4, very heavy, right? You can remember drug given is A, B, C, D. Crossover, you turn it another round, D, A, B, C. Another round, C, D, A, B, and so and so. Very complicated, right? So calculation of sample size also not very simple, a bit complicated. So that's why I suggest you recruit a medical statistician, right? Okay, so don't worry, for clinical trial, community trial, I will come back to that calculation of sample size, right? How to go for it. Okay, so I've introduced you experimental study, that is for clinical community trial. Now I'm coming back to observational studies, right? In observational studies, right, as we all know, 3C, what are they? Cohort, case control, cross-sectional. So if you look at the classification bag, cohort has 3 types: prospective cohort, retrospective cohort, historical cohort. So historical, I will not introduce it. These days, much less, not like last time. But prospective and retrospective cohort are quite common. Case control studies, you have unmatched, matched, and nested case control. So basically, I'm not going to detail about it. I just say the case control study. I would demonstrate. If they are matched, I would demonstrate for match also. Cross-sectional studies, you have a classical cross-sectional study, comparative cross-sectional study, diagnostic tests is under cross-sectional study also, and also the questionnaire study are also questionnaire-based studies are also cross-sectional studies, right? So I will try to touch and go, and also for descriptive study is a prevalence study, the single proportion, right? Okay. If you have any question, please stop me anytime. Observational studies, prospective cohort, right? Prospective cohort study start from exposure, non-exposure to disease, no disease. Researcher is right in the middle. Exposure happened already, disease not happened yet. You are interested in proportion of disease among exposed group, proportion of disease among non-exposed group. I repeat again, prospective cohort study, key point is proportion of disease among exposed group, proportion of disease among non-exposed, not an unexposed group, right? So for that, if you are comparing proportion of disease among exposed group divided by proportion of disease among non-exposed group is known as relative risk. Relative risk. So relative risk is the one that we're going to measure risk in prospective cohort studies, right? That's why I mentioned about proportion. Can I ask you, how many proportions here? Let's do it two-way teaching, right? Not one way. You ask me. How many proportions here for you to calculate sample size? You understand my question? How many proportions you have? By right, you have 4 proportions. Is it right? Proportion of disease man exposed group, proportion of no disease man exposed group, proportion of disease man unexposed group, proportion of disease man unexposed group, proportion of disease man unexposed, proportion of no disease man unexposed group. However, we are interested only in disease. For information, prospective cohort is interested in disease, right? So proportion of disease among exposed group divided by proportion of disease among non-exposed group is known as relative risk. Relative risk. It is a true risk, is the best risk. Among all risks is the best, right? Why? Why is the best? The reason why it's the best is it comes from incidence. What is the incidence? Disease, proportion of disease among exposed group is incidence, right? Incidence among exposed group. Proportion of disease among unexposed is also incidence. Incidence of disease among unexposed group. So, if you have these 2 proportions, you ratio it, that is called relative risk. Right? It's a prospective cohort study. Case control. Case control study is actually start from disease, interested in exposure. So, difference between case control and prospective cohort is case control start from case and control, look back, exposure. Okay? So, case control is interested in exposure. Cohort is interested in disease, right? So proportion of exposure among disease cases divided by proportion of exposure among cases divided by proportion of exposure among control is known as odds ratio. I repeat, proportion of exposure among cases divided by proportion of exposure among controls, right? That is called odds ratio. How do you interpret odds ratio of relative risk? Equal to 1, no risk. More than 1, there is a risk. Less than 1, protected from risk. We call it protective factor, right? So by the point for sample size calculation here is that you are going to use again 2 proportions. Can I ask you, what are the proportions? How many proportions? 4, right? Exposure among cases is no exposure among cases. Exposure among controls, no exposure among control, right? Okay. So basically, you are interested in exposure among cases divided by exposure among non-countries or control, right? So when we calculate it, odds ratio, same thing, equal to 1, no risk. More than 1, there is a risk. Less than 1, protected factor. Right? So that is case control study. Case control study measurement is odds ratio, cannot be relative risk, right? Case control studies are actually very good for rare outcome, rare disease, right? Rare disease. Last one is cross-sectional studies, PC, right? From the population, draw a sample, exposure and disease association. For information, cross-sectional studies are not meant for risk assessment. Cross-sectional studies are meant only for correlation or association, right? So here you have an exposure and non-exposure, disease and no disease. Just do the correlation. In very old textbooks, cross-sectional studies are known as correlational studies, right? Correlation, just correlation. So it is not meant for measuring risk, right? It is just for looking for the association, right? Okay. So there is another one more called cross-sectional study. Another one more is comparative cross-sectional studies, right? It is look at the population, draw samples, and do the analysis between exposure and disease, right? So comparative cross-sectional means you are having, for example, you are looking for the what you call the difference or proportion of obesity among primary school children in 2 states, right? Selangor and Sarawak, for example. In that case, population one is Selangor, population 2 is Sarawak, right? Sample 1, sample 2 they are from sample, Selangor sample, what you call Sarawak sample. And you look for the, what you call the, looking for the associated factors, right? So you combine together what are the whatever what you call variable they have in the run it, and then it is called comparative cross-sectional study. There are many more examples of comparative cross-sectional studies. Because of time, I cannot tell you, right? Okay, so again, you use two proportions, right? Two proportions. So if you look at here, prospective cohort proportion mostly. Retrospective cohort I've touched on it already. Case control, most probably proportion also, right? And then cross-sectional study, right? So for example, the population draw a sample, do the statistical analysis for primary school children in Terengganu, for example. That is the classical cross-sectional study. And some people may do comparative cross-sectional study for more population, right? So this is the present for you. Me and my wife, Dr. Arfa, we did an illustration for you, right? Prospective cohort, retrospective cohort, case control, cross-sectional, right? You may not find it in the textbook. This is our own flow chart, right? So prospective cohort study, exposure, non-exposure, disease happened already. Disease not yet happened, exposure happened already, researcher is here, right? You calculate RR, this is the prospective cohort study. Retrospective cohort is same as prospective cohort. It tried to imitate prospective cohort. However, it is disease and exposure both happened already. So you cannot use relative risk. You have to use IRR or OR. Case control studies. They are cases and controls studied, interest and exposure, right? Prospective cohort, retrospective cohort are interested in disease. Case control study is interested in exposure, right? Start from cases, control, exposure. But that is case control study. Case control studies are meant for rare outcome. Meant for rare outcome. If it is rare, you have to use case control study. If it is common, you can use prospective cohort, retrospective cohort, cross-sectional. Right? This is the cross-sectional study. From the population, draw a sample and do the association between exposure and. Okay, so this is about study design. Any questions so far for study design? My introduction, the fundamental things not finished yet. Any question for study design? Ziwi, you want to ask any question?
Assalamualaikum.
Salam.
Dear Prof, I have a simple question.
Okay.
Pertaining to the crossover design just now.
Okay.
In terms of the analysis, right? Analysis, are we comparing means between when we switch between the subject and the control, right? When we switch, how do we compare the means?
Okay. There are a number of ways to calculate, a number of ways to do analysis for crossover design. The common way to do is they have an identifier variable. What is identifier variable? It is this particular subject is you get what you call test drug first and later control drug. This particular participant is control drug first and later test drug, right? Based on that, we are going to look for the difference of mean, for example, blood pressure reduction. So we need to do it based on, we have to format the data entry very well. Based on that, we can calculate. So when result come out, very clear. Result is how blood pressure reduction is there, mean blood pressure reduction, or other way around is you don't have an identifier. As it is, you enter data, and then you analyze and interpret in such a way. You need to remember that the which subjects are so and so, how to compare, right? So maybe a little bit not easy to explain online. If you have data and if you want me to explain, I can explain you how to enter data, how to analyze and interpret and conclude. Right?
Thank you, Sir. Thank you very much.
Okay, welcome. Any more questions? Before going to other fundamental knowledge, the other fundamental things. Okay, if you don't have, can I proceed? Do you need a break? Dr. Zimi, do you need a break?
I don't think we need it. Prof, we may proceed.
Okay.
Thank you.
So I have introduced study design quite in detail. Now the other part I must introduce you is what you call basic fundamentals of differential statistics. Without knowing it, without remembering it, without recalling back it, you cannot appreciate the sample size calculation. What is it? Actually, I'm going to explain this one. I think many people may have forgotten. Many people may still remember. One error, type 2 error, right, so and so. So for this, I am going to use the non-statistical example first. The non-statistical example from Harvard University. Right? When you are going through a criminal trial, right, there is a jury, right? Jury will give the verdict. So defendant and jury, right? Defendant is innocent or guilty. Verdict of the jury is not guilty, guilty. Right? So there are four probabilities. Probabilities. We use a statistical jargon, probabilities, right? Defendant, if you look at 4 cells here, defendant was innocent, verdict give not guilty, correct verdict. Defendant was guilty, verdict give guilty, correct. Defendant was innocent, but verdict give guilty, incorrect. Jury verdict by the jury. Defendant was guilty, verdict give not guilty, incorrect. The point I want to make here is that when you compare your defendant and verdict by the jury, 2 probabilities are in correct verdict, other 2 probabilities are in incorrect verdict, right? That's the only thing I want to give you this message. But coming to statistics, same thing. This is in the population, this is the sample. As we all know, when we do statistical inference, or in other words, statistical analysis, we have to draw a sample from population. Population is too big. We cannot do it population. So you have to draw a sample from population, right? And based on the population, we do the statistical analysis, we test the hypothesis, right? Together with the confidence level, and you are going to infer back to population parameter. That is called statistical inference, right? So same thing here. Null hypothesis is true, null hypothesis is false in the population. Statistical decision based on sample, do not reject. For example, null hypothesis is true in population, that is, smoking and heart disease are not associated. There is no association between smoking and heart disease. Null hypothesis is true. Null hypothesis is false, means there is an association between smoking and heart disease. So from the population, draw a sample, do the statistical analysis, right? Of course, you need to have good sample size, right? And you are going to have statistical decision based on sample, inferring to population, right? So statistical decisions make that do not reject null hypothesis. Null hypothesis is true. Do not reject null hypothesis. Correct statistical decision, 1 minus alpha or confidence limit. Look at the last cell. In the population, null hypothesis was false. Smoking and heart disease are associated. Researchers did the statistical decision based on sample and correctly reject the null hypothesis, correctly reject the null hypothesis and accept the alternate hypothesis and conclude that there is an association between smoking and heart disease. In fact, in the population, there is an association. That is called correct decision, 1 minus beta, power of the study. 1 minus alpha, correct, confidence limit. 1 minus beta, correct, power of the study. Third one, in the population, null hypothesis was true. Smoking and heart disease are not associated, Researcher did this study and make the statistical decision and wrongly reject the null hypothesis. Conclude that there is an association. Reject the null hypothesis, accept the alternate hypothesis, conclude that there is an association. In fact, in the population, no association. False positive or type 1 error or alpha or level of significance. Type 1 error is called as alpha, level of significance. Basically, it's a false positive, right? Reject and say that there's an association. In fact, no association. The last one is type 2 error. Now, in the population, null hypothesis were false. Smoking and heart disease are associated. Researcher wrongly do not reject the null hypothesis and conclude that there is no association. In fact, in the population, there is an association. False negative. False negative, known as type 2 error or beta. So this is type 1 error. This is type 2 error, alpha, beta. This is confidence limit 1 minus beta, 1 minus alpha. This is power 1 minus beta. So after understanding it, so what? What is the application? Right? After knowing it, what is the application? Application is very straightforward. When you calculate your sample size, right, in your proposal, when you write it, you need to determine all. Right? I always encourage people to start from type 1 error. Type 1 error, what is your, how much do you fix? Normally, type 1 error is how much? Please participate. If I talk alone, you will be sleepy, I will be sleepy, right? What is the type 1 error? If you don't want to talk, you can type. You can type in the, what you call the chat, right? So what is your, normally you set alpha how much? Ziwi? Normally?
Nobody would like to type, Prof.
Don't type, just talk. Don't to talk also. This is a learning session. Wrong, never mind. Yes, use the 0.05, correct? 0.05 for general statistical concept, right? If you are doing clinical trial, if you are doing some public health studies, you can set as 0.05. What do you mean by 0.05? 0.05 means whenever you make statistical decision 100 times, you are allowed to wrongly reject the null hypothesis, by 5 times. Whenever you do a statistical decision by 100 times, you are allowed to wrongly reject by 5 times. So 5 times, is it enough? Right? Some people in laboratory-based medicine, they may say that no, our study is stringent. We want to set alpha as 0.01. What does it mean? Out of 100 times, you are allowed to wrongly reject the null hypothesis by only 1 time. Remember, can you afford? Only 1 time. Very stringent. But some laboratory-based medicine people, they do it. They are confident they can do it, right? People in public health medicine, community medicine, psychiatry, psychology, field-based epidemiology, they may set as 0.1, meaning 10%, right? Out of 100 times during statistical decision, 10 times allowed to wrongly reject the null hypothesis. Much flexible. Why? People in community medicine, people in psychiatry, psychology, their measurement tools are sometimes very broad scope, right? With the questionnaire very long, right? Many items in the questionnaire, many constructs, many domains, right? In that case, recommended is no worries. You can increase your alpha. I mean, you can make alpha more flexible by putting at 10%, right? No problem. You can go till 10%, right? For those who are working in field work, they need it, right? So, but implication you have to remember. Implication is if type 1 error you set most stringent, sample size will be larger or smaller. Common sense. If you put the alpha most stringent 0.05 and 0.01, which one will be sample size bigger? Common sense. Bigger will be more stringent. 0.01 will be bigger sample size. Am I right? Right? So, if your type 1 error is more stringent, you need a bigger sample size. Right? So, that way you need to be careful. 1 minus alpha, going to 1 minus alpha, if you set 0.05, 1 minus alpha is 95% confidence limit. If it's 0.01, 99%, 0.1, 90%. Right? Type 2 error. Probability of wrongly not rejecting the null hypothesis. One null hypothesis is false. False negative. Right? So type 2 error, how much do you set? Observational studies, type 2 error, 0.2, 20% minimum. Right? And for interventional studies, type 2 error, 0.1, 10%. Right? So type 1 error, type 2 error, sorry, type 2 error is observational 20%, interventional 10%. It is fair enough. Interventional studies should have less error, 10%. Then what about 1 minus beta? If you set beta at 20% for observational studies, power should be 80%. If you set interventional study at 0.1, 10%, your power should be 90%. Fair enough, right? Some people put power more than 90%, 95%, so and so. What happened? You can, right? However, you need to remember, the higher the power, the larger the sample size, right? So you need a sample size, larger sample size for higher power. So many people write power when I used to see many times in application for research and ethics committee or even the department level, power put as beta. Wrong. Power is not beta. Power is 1 minus beta. Right? Be careful, right? Many people wrote wrong. Power is beta. No, power is 1 minus beta. Beta is type 2 error. So can I ask you true and false, right? I need to stimulate people to wake up, right? Please don't listen to my lecture only. What you call? You need to talk, right? Type 1 error, type 2 error. 1 minus alpha, 1 minus beta. If I give you a MCQ question, true, false, can you answer me? Type 1 error and sample size are directly related. True or false? Type 1 error and sample size are directly related. True or false? Type 1 error, more stringent, sample size should be larger. Type 1 error, less stringent, sample size should be smaller. So I ask you question again. Type 1 error and sample size are directly related. True or false? Ziwi should answer. You just came out from course last year only, right? Ziwi?
True.
True? Type 1 error and sample size are directly related. Do you agree with Ziwi? Other people? True or false?
Prof, some agree with me, some don't agree with me.
Yeah. Okay. What do you mean by directly? What do you mean by directly? If alpha is stringent, means smaller, is it right? Alpha is smaller, am I right? So smaller means 0.055% and 0.011%. Smaller, sample size is bigger. So correct answer is type 1 error and sample size are inversely related. If you say directly related, means it is false. Type 1 error and sample size are directly related, means it is false. It is inversely related. What about type 2 error? Type 2 error and sample size are inversely related. True or false? Type 2 error and sample size are inversely related. True or false? If type 2 error is false, correct. Inversely related, sorry. Your answer is false, right? Sorry. Type 2 error and sample size are inversely related. Can I explain you? If type 2 error is 0.2, 20%, then power is 80%. Am I right? Power 80%. If type 2 is 10%, power is 90%. Can I ask you, 90% and 80%, which one needs sample size bigger? Common sense, 90% bigger. Is it right? So, less stringent, yes, 90%. Less stringent type 2 error, you need a smaller sample size. Am I right? If it is type 2 error is 20%, power is 80%, sample size is smaller, you need. If it is type 2 error is 10%, more stringent, sample sizes, you need a bigger sample size, 90% power, right? So, correct answer is type 1 and type 2 error, both of them, they are inversely related to sample size. Power is directly related to sample size, right? You have a bigger power, higher power, sample size needed. So it means sample size, you need a larger sample size. So 1 minus beta or power is directly related to sample size. Type 2 and type 1 error are inversely related to sample size, right? We used to ask in postgraduate students, many got wrong, right? So my point is very simple. If error, just remember, type 1 and type 2 error, both of them, they are inversely related to sample size, inverse. Power is directly related, right? Of course, confidence limit is depending on alpha, same thing, right? So we don't talk, of course, confidence level also important. If confidence level is narrow, sample size is narrow, inference is better. Sample size, confidence level is wide, inference is not good, right? So why confidence level is wide? Why confidence level is wide? Because small sample size, right? If you still remember confidence level, all right, confidence level equal, this is the formula, confidence level equal estimate plus or minus k into standard error, right? So standard error equal standard deviation divided by square root of n. So it is sample size there. Sample size small, confidence level is sample size small, standard error is big, confidence level is wide. Sample size big, standard error is small, confidence level is narrow. So conclusion, sample size small, confidence level wide, sample size adequate, large, confidence level is narrow. So confidence level narrow is better, right? So in other words, sample size is so much giving impact on our fundamentals of fundamental measures of inferential statistics. That's why sample size must be considered seriously, right? Okay, these are just for your remembrance. And the precision, the other one I need to mention, precision means width of the confidence level, right? Power mean probability of rejecting null hypothesis when it is true, when it is false, right? So these things I think you can remember back. Confidence level, or just now I mentioned about confidence level. When you talk about inferential statistics, you cannot forget about confidence level, right? So confidence level is estimate plus or minus k into standard error equal standard deviation divided by square root of n. So n is sample size, right? Sample size small, standard error big, confidence level wide. Sample size adequate or large, standard error is small, confidence level is narrow, right? So confidence level, there are many people, postgraduate students, lecturers, when they analyze, confidence level is so wide, right? Then afraid how to publish, how to graduate, right? So basically, confidence level wide means majority of the cases is because of sample size. Sample size small, confidence level wide, right? Sometimes too wide, cannot present. Then you have no choice. You need to think about something else to do it, right? Confidence level lower bound is 50, upper bound is 1000 plus. That kind of situation, definitely sample size is too small for that particular group, right? So you need to consider that, right? These days, confidence level is very important, right? When you publish your manuscript in the world, for inferential statistics, p-value is not, many journals, they don't ask it anymore. But they always ask confidence level. Even Malaysian journals, some journals, they don't ask p-value anymore. They ask confidence level. So confidence level too wide, journal will think about whether to publish or not, right? What do you mean confidence level too wide? Sample size is small, statistical inference is not very good, right? So that one you need to think about it, right? So basically, this is just for your remembrance, right? What do you mean by confidence level? Confidence level, the population parameter fall within the confidence level of sample statistics, right? These are theory, right? And so sample size is confidence level is very much depending on sample size, right? So that one just to. So fundamental things finished already, right? My first component finished already. I have introduced back, just to recap back, I have introduced back, sample size, study designs to you, different study designs, and also what are the fundamental things that you need to know for alpha, beta, 1 minus alpha, 1 minus beta, all these things I have revisited with you together. I hope you remember back, right? So my first component finished. Any question you want to ask before going to second component? Any question? For crossover design analysis, the one asked me, you can come back to me, I will explain again. Any other thing you want to know?
Prof, in view of time constraint, I think we shall proceed.
Okay.
Thank you.
Okay. So if you don't have any question, I'll proceed. Now we are going to calculate sample size. How are we going to calculate sample size, right? So as far as I know, there are 4 approaches to calculate sample size. Formula, using formula, statistical software, actually basically a sample size calculation software, but some are inside statistical software. You can calculate, or there are specific sample size calculation software available. Majority of them are free of charge, right? So you can download. Some, very few software may charge, right? And for information, many universities are competing each other to produce more efficient sample size calculation software. So if you want to get it, even you can write to the author. Author will give you free of charge. They will send you, by email or by some you have to, download, some are straight away you can use, right? The third approach is sample size tables, right? Tables are long time already, 1970s, 1980s started tables. Some are very old. Table now there are newly developed tables available. The last one is nomogram, right? So for nomogram is also a very old method, right? So for me personally, I prefer first and second method. I seldom use third one. I think I never use last one, right? So third one is sample size table. If they are updated table, I may use. Otherwise, I rely on formula and statistical software. So for your information, just to give you some tips, right? If you want to submit your proposal, either to research committee or to postgraduate committee, anyone, use either one. You calculate by formula, use formula by hand, right? If you do by statistical software, by software, and you take the software print out, or you take the screenshot and so and put it in your document or PowerPoint, anyone. The reason being, formula and statistical software calculation, if you put together, you put the formula, but you calculate by software. Sample size are sometimes a bit different, sometimes quite different. So committee will query, right? There are some committee members, they calculate like me. I straight recalculate. When I see the proposal, I have a computer or my handphone with me. I calculate by my laptop or by my handphone or by my hand calculation. I straight recommend, right? Sometimes we got researcher put the proposal as formula, but calculate by software. Sample size is different. So it is a waste of time where you have to correct it again. right? So if you want to submit by formula, if you submit by software, that's all. Don't mix both of them, right? Just for the tips, many researchers, they got this problem, so they have correct back, right? Both are okay, not much different, right? Sometimes quite different. So you have a single mean, single proportion, two means, two proportion, research design, independent or dependent sample, so on, right? So I want to give you, for that, you can calculate sample size by using number of software, whatever software you use it, the reliable software. So there are many software in the market. So just for the demonstration purpose, I use only two software. One is power and sample size software from University of Vanderbilt. And another one is EpiInfo software, where many people used long time ago, right? EpiInfo software, now they have quite established one. They developed quite well, right? So some I may use power and sample size, some I may use EpiInfo software. And another software I regularly use is Starter software. Starter software, STATA. Starter software is a statistical software, but inside there, very nice. They have sample size calculation a lot, and the Starter is they have quite a good collaboration with PS software, the Vanderbilt, University of Vanderbilt. So some features are quite similar, right? To determine sample size, I want to give you, these are my tips. These tips, you can use it, 5 tips, right? 5 tips in determining a minimum required sample size. First question is, what is the research design? Second, what is the study design? Third, are the means or proportions? Fourth, it means, how many means? It proportions, how many proportions? Last one, is it an independent or dependent study? These 5 tips may not be applicable for all sample size calculation, but majority of them, especially when testable hypothesis is there, majority of study, majority of proposal can answer by these 5 tips for sample size calculation, right? So I repeat: number 1, what is the research question? Number 2, what is the study design? Number 3 is a mean or proportion. If mean, how many means? If proportion, how many proportions? And is it an independent sample or related or dependent sample, right? So whenever you calculate sample size, ask yourself, right, these 5 tips. Let's start it. I'm going to start with 2 randomized controlled trials, right? Randomized controlled trials. So I'm going to use 2 means, right? So 2 means here, your 2 means this formula is for 2 groups, right? So n equal to sigma square, and the triangle one is called detectable difference, right? This is sigma, is a standard deviation. This is expected detectable difference between 2 groups, and z alpha plus z beta whole square, right? 2 sigma square, right? The detectable difference delta, we call it delta square, plus z multiplied by z alpha plus z beta whole square. What is z alpha z beta? No need to remember. Z alpha is 1.96 for 0.05, 2.5 for 0.01. Z beta is 0.84 for 80% power. Z beta is 1.28 for 9% power. Right? So if you look at it here, the one that I mentioned about alpha, 1 minus alpha, beta, 1 minus beta, all are there. Where is alpha? Alpha is 0.05. Where 1 minus alpha is 95% confidence interval, right? What you call it is understood 95% confidence interval because alpha is 0.05. Where is beta? Beta is represented by 1 minus beta. 1 minus beta here is 80% power. 1 minus beta means beta is 20%. 90% power. 1 minus beta means beta is 10%, right? So all are there. This value, put it in. And here, very important, I want to tell you some tips, right? Sigma and delta, detectable difference, where to get it? Sigma is standard deviation. We are comparing 2 groups, right? Standard deviation of either group. So in your literature, you may find, let's say you are comparing drug A and drug B, right? So you may find sigma for both groups, A and B, right? Normally we find in literature is, let's say A and B, A is new drug, B is old drug. Normally we see old drug. It means a drug B. Standard deviation or in drug B group, you will get it. You may not get what you call drug A group because it's a new drug, right? If you don't get both drugs, standard deviation, never mind. You take the old one available, take it, right? So standard deviation. If you can get both of them, somebody has done already for drug A, new drug, then you compare. Which standard deviation is bigger? Please take the bigger standard deviation. Why? If you look at the formula, bigger standard deviation gives the bigger sample size to make it safe. I repeat again. In literature, you may find old drug only, standard deviation. Take it. If you find both drugs there, then take the bigger one. Because bigger standard deviation gives the bigger sample size. Right? Remember, 2 means it is based on 2 independent t-tests. 2 independent t-tests. In 2 independent t-tests, one of the assumptions is equal variance. Equal variance. Variance comes from standard deviation. In other words, equal standard deviation. So you can use either standard deviation, but preferably we encourage you to use bigger standard deviation. So standard deviation comes from literature. That is the major point. Standard deviation comes from literature, right? You have to go back to the best is for the last 5 years, right? Recent one, right? You take the biggest standard deviation. Down there is detectable difference, delta. Where do you get delta? Delta comes from expert opinion. Delta comes from expert opinion. So you must remember, standard deviation comes from literature. Detectable difference, delta, comes from expert opinion. What do you mean by expert opinion? For example, you are comparing drug A and drug B. Drug B, there's a literature because it's an old drug, right? So mean blood pressure reduction in drug B is so and so, right? For example, mean blood pressure reduction is only 5 millimeter mercury, right? By using that drug. But you are going for drug A. Drug is new drug, right? Drug B is old drug. Drug B literature say that the blood pressure reduction is 5 millimeter mercury only. Drug A is new drug, not in the literature. Maybe your study is the first study, for example. So how are you going to get mean blood pressure reduction for drug A, not in the literature? Then you have no choice. You have to predict. How do you predict? Your prediction must be biologically sound, clinically plausible. Right? We use the word plausible. Clinically plausible means clinically meaningful. So clinically plausible detectable difference you have to determine. That is called your expert opinion. I repeat, clinically plausible detectable difference you need to come out. You are expert in this area. You know better than statistician. You know better than others, right? So don't ask statistician to determine the detectable difference. Statistician does not know your detectable difference you are expecting. So your expectation must be biologically meaningful, clinically plausible. Drug B is the old drug from literature, blood pressure reduction in 5 millimeter mercury. What about drug A? Drug A is new drug. Are you expecting less than or more than blood pressure reduction for drug A? Less or more? Clinicians, please answer me. Are you expecting less or more? Yes, more. Yes, more. Why more? If you are expecting less than the usual drug, old drug, you don't need to do this research, is it right? You don't need to propose a trial. You are expecting less blood pressure reduction than old drug. You don't need to write this proposal. You are definitely expecting more than the usual drug or old drug. Then you have to predict. Your prediction is, I think blood pressure reduction should be 10 millimeter mercury, right? Or 50 millimeter mercury. Old drug is only reduced 5 millimeter mercury. New drug is either 10 or 50. If you 10 means 10 minus 5 means 5 millimeter mercury, your delta is 5 millimeter mercury. If you are expecting 50 millimeter mercury reduction in new drug, then 50 minus 5 means 10 millimeter mercury. You are expecting your detectable difference. That is all your expert opinion. Nobody get a question because you are the expert in this area. You are the one who write this proposal. And you are the, for example, physician, or you are the what you call the postgraduate MS student, and you have done a lot of literature for this and so, or you may have a pilot study, for example, right? Then that is called expert opinion, right? So this expert opinion is respected as an expert, right? So this difference is called detectable difference. Bear in mind, this is the denominator. Detectable difference you expect is large, sample size is small. Detectable difference you expect is small, sample size is larger. So if you look at it here, what are the factors affecting on sample size? Z alpha and Z beta, of course, if you based on your either 0.05 or 0.1, it will be different. Z beta, either it is a what you call power study, right? If beta effect on 1 minus beta, power study is the 80% or 90%, they'll be different. And definitely sigma affects on sample size. Sigma is large, sample size is large. Sigma small, sample size small. The larger the sigma, the larger the sample size. And don't forget detectable difference. From expert opinion, detectable difference is small sample size. You need a bigger sample size. Detectable difference is big. You need a smaller sample size. So don't forget, sigma comes from literature. Delta comes from detectable difference. Delta comes from expert opinion. Are you clear? Right? So these are the points. The two means formula. Let's go for parallel design. Like just example. Example. Not example 4. I use a lot of examples. This is actually example 1, right? A new antihypertensive drug is to be tested against current treatment practice in people with systolic blood pressure 160 mm mercury and diastolic blood pressure 95 mm mercury. It is felt that if the new drug can achieve blood pressure levels that are on the average 10 mm mercury than those achieved using current treatment, then it would be accepted by the medical community. What does it mean? All the patients are hypertensive patients. This is a clinical trial, right? Based on the criteria, they are all hypertensive. So they have a new drug and current drug, right? So new drug and current drug. If new drug can reduce the blood pressure by 10 millimeter mercury, that is called delta, detectable difference, 10 millimeter mercury, then this drug will be accepted. Investigators would like at least 90% power with alpha 0.01. Very stringent. They want a 90% power, 1 minus beta, and they want alpha, which is called 0.01. Normally 0.05, but this group of researchers, they want alpha most stringent 1% only, right? Alpha 0.01%, so sometimes we bigger, two-sided, right? As the current therapy is quite acceptable, and they want to make sure that new therapy is superior before switching over. Blood pressure measurement has a standard deviation of 20 mmHg from literature. So you understand the question, right? So look at this is a clinical trial, 2 drugs, new drug and old drug, current drug, and they want to accept this drug, new drug, if it can reduce blood pressure 10 millimeter mercury more than the usual drug. They want to do the the study with alpha 0.01, not 0.05, alpha 0.01, and they have found out that standard deviation from literature is 20 millimeter mercury. Most probably standard deviation is from old drug, current drug, right? So the formula alpha 0.01, detectable difference between two is 10 millimeter mercury. Z alpha is 2.58, beta is 0.1, alpha 0.1, that is what you call, because 90% power, right? So the beta is 0.1, 1 minus beta is 0.9. Standard deviation 20, the difference 10, therefore is the beta value. Put in the formula, you got 119 per group. Remember, this sample size calculation for interventional study for clinical trial here gives, this formula gives 190 per group, right? It means that 119 for usual drug, current drug, 119 for new drug, right? And we always recommend you to calculate sample size by adding 10 to 20% dropout or death or missing data or loss to follow up or what you call withdrawal or any type. We encourage you to add 10 to 20% dropout. Some people even go for 30%, right? Okay, so let's calculate by software. So I forgot to tell you to download the software. Anybody who is following by software? Or I just demonstrate first. See, what do you think?
Continue, Prof. We will have a question later on.
Okay, no, what I mean is, are you going to follow by software or I just demonstrate?
I think just demonstrate. They don't have, not many people having this.
Okay. Yeah. Where's my software?
Prof, maybe you could proceed and I will share the link to download the software.
Okay. Wait. I just increase the RAM and the computer. I don't know whether
You just type down there, Prof. Type PS software. You want to use PS software, right?
Yeah. No, I mean I sent for computer RAM. I don't know whether they deleted or not.
Or you maybe just type down there under the type here to search, then they will come out.
Yeah.
Search PS.
Yeah, PS.
It is not there, Prof.
Yeah,
Yeah. Okay. I think. Sorry. I did not check.
you have to download.
But the download is just for only a few minutes only.
And then later, maybe you can proceed the PowerPoint.
Okay.
I just show the PowerPoint.
Can you see the screen that I'm doing now? Can you see? You don't see, no?
Yes. Prof, in the search, you need to type PS.
Yeah. Okay. Okay, done already. Okay, can you see this? Can you see the screen?
Yes, Prof.
Can you see?
Yes.
Yes.
Okay. So power and sample size here. If you look at it here, sorry. Okay. So this software, there are some applications here, but today I will show you only one. That is t-test here, right? T-test. T-test for difference of mean, right? Whereas in dichotomous for difference of proportions, right? So here you will use the independent t-test, pair t-test, and so and so. This is for Pearson coefficient and so, right? For sample size calculation, right? Okay, so just say t-test. Software will ask you, what do you want? You want a sample size, power, detectable difference, detectable alternative. So I want a sample size and pair or independent sample. Just now, the clinical trial is there are two groups, right? Usual drug or current drug and new drug, right? So independent sample. So software will ask you, what is your alpha? You set it 0.01. Remember this particular study is 1% only alpha, right? Power of the study 90%. Alpha, delta mean difference, right? Delta mean detectable difference, right? So if you don't know, you can click here. Can you see? Can you see the screen? You can read here, right? You can read what is delta. Delta mean difference in population means. What is sigma? Independent t-test is the within group standard deviation. For pairs, the design is the standard deviation of difference and so, right? And then A mean ratio. A mean, what is the ratio between control to experimental group? So in our study now, what is the control group? Control group is current drug, right? Experimental group is new drug, right? So you want a ratio. For example, you want a ratio of only 1. 1 means control 1, experimental 1. It means the current drug is one patient, and then the new drug is 1 patient. If you put as 2, then current drug is 2 patients, and new drug is 1. So when are you going to increase the ratio? When you increase the ratio it should be increased when samples are difficult to find, right? In that case, preferably current drug should be higher than new drug, not other way around. New drug is 2, current is 1, then every pair, a new drug is 2 patients and current drug is 1. That is not really recommended. Better one is new drug is 1, current drug is 2. That is better, right? So now this case, for example, in this, we want 1 by 1, 1 to 1. This is a delta, the detectable difference. In this example, they are looking for the delta of 10, right? 10 millimeter mercury, and sigma is, remember, in the question, 20 millimeter mercury, right? Okay. For clicking calculate sample size, I want to remind all of you here, one thing you need to be very, very careful. What you have to be careful is delta and sigma relationship. Delta and sigma relationship for like this kind of case, two independent mean called the calculation. You need to be careful about one particular situation called effect size. I think many clinicians, many public people, you know about effect size. Effect size are 2 types: absolute effect size and relative effect size, right? So here, this effect size here is calculated here, delta divided by sigma. Delta means detectable difference, sigma means standard deviation. So the effect size is equal to detectable difference divided by standard deviation, delta divided by sigma. Effect size should be, according to Kohan, right, 1998, Kohan mentioned that effect size should not be more than 1. In other words, delta divided by standard deviation should not be more than 1. If it is more than 1, what does it mean? Delta is bigger than standard deviation. Delta is bigger than sigma. What does it mean? You are looking for the so much difference of blood pressure, millimeter mercury, direction between two groups. So if you are looking for the very big difference, standard deviation is small, your effect size become more than 1. Effect size more than 1 means sample size is very small, and statisticians, epidemiologists, clinical epidemiologists, they don't accept because sample size is too small, power is small, so the statistical inference is not very good, and confidence will be very wide, just how I mentioned, right? So all affected. So effect size is less than 1, it is reasonable. So effect size has 3 types, right? If you can look at in the Cohan, COH and Cohan, Cohan recommended that there are 3 types of effect size: 0.2, 0.5, 0.8, right? 0.2 mean small effect size, 0.5 mean medium effect size, 0.8 mean large effect size. So for me personally, my cutoff point is 0.8. I don't go lower than 0.8 for effect size, right? Sorry, I don't go larger than 0.8. Lower is no problem, right? Lower the effect size, sample size will be bigger, so that is reasonable, right? If more than 0.8, I don't go for it. But the cutoff point for many researchers is effect size is 1. So my point is, if you found out that your effect size is more than 1, what does it mean? Delta is bigger than sigma. Don't submit your proposal. Trust me, don't submit your proposal. Most probably it will be rejected, especially in the committee. For those who are familiar with some size calculation for clinical trials, especially medical statisticians, they will reject it. I used to reject many, right? Because my principle is very simple. We reject now, better, right? Researcher will not face problem later, right? If sample size is too small, effect size is more than 1, researcher may face a lot of problems, including confidence interval, later effect p-value, and many things, right? So please check back. Your effect size should not be more than 1. In this case here, if you look at it here, delta is 10, sigma is 20, mean effect size is 0.5. Am I right? 10 divided by 20, 0.5. There's the medium effect size. That's okay. Go ahead, right? If other way around, 20 is above there, 10 is down there, become 2, don't submit your proposal. Very high chance your proposal will be rejected, right? And don't talk about publication, right? Publication definitely cannot go in, right? So that is called effect size, right? Are you clear, right? Okay, calculate 1 to 1. Sample size is 1 to 1, right? So by our hand calculation, how much just now? Hand calculation was 119 per group, right? But by software here, we calculated software is 121. So software may calculate a little bit larger than the software. Sorry, the hand calculation. So that is okay, right? Okay. So here you may draw, for those who want to submit your proposal, you may draw a graph nicely here. Let's say, for example, you want the X and Y range. You want to draw the power, right? Power, and your power is 0 to, let's say, your X is sample size is, now you have the 121 per group. Let's say make it 125, number, right? You can draw a nice plot here. You can put in your proposal, right? So what does it mean? Here you have the 90% power, sample size needed is around 120 plus something, right? 121, something like that, right? So this is a way you can copy and paste inside your Microsoft Word or PowerPoint. This is for postgraduate students, for lecturers, you can use it, this graph, very meaningful graph, right? Okay. So that now we have 121 per group, right? Don't forget, clinical trials, withdrawal is common, death is common, right? Loss to follow-up is common. So you need to add minimum 10%. right? Minimum 10%, adding for missing data, withdrawal, and so and so. So add another 10% or 10 to, maximum is 30%. You can add 10 to 30%, and that will be the sample size per group. Don't forget, per group, right? You calculate for one group, 121, add let's say 10% and multiply by 2. That is of total sample size, right? Are you clear? Are you clear? I want to add one more thing here. Sometimes your sample size could not be achieved. Sample size you need 121, but end up with sample size is I got only 110. Can I ask you, if it is 110, will your power still be 90%? Your predetermined sample size is 121 per group, right? So happen that your samples, you cannot get enough sample, 121, right? So you got a sample size of 110 only. Then question is, are you doing your clinical trial with 90% power or not? Your predetermined power was 90% with sample size 121. But now you 110 only. Then you need to inform the reader, inform the the editor if you want to publish, or you are postgraduate students, you have to write in the thesis, you need to calculate post-hoc power. POST, post, HOC, hoc, post-hoc power. How to calculate? Post-hoc power, keep like this, you are going to calculate back power. And here, everything is the same, just change here 110. 110, take it, your power is 86.6%. 86.6%. Can you see? Can you see the here? Can you see here? 86.6%. So please write in your methodology that the post-hoc power. Researchers, the predetermined sample size by researchers was 121 per group. However, because of some problems or logistic problems, sample size achieved at the end of the trial was 110 per group only. Therefore, post-hoc power at the end of the study was 86.6%. Right, honestly. Then it'll be okay. 86.6% is still good, right? So that is the thing. Please don't forget to write. If you don't write, sample size is smaller than the required sample size, and you don't inform post-hoc power, the reader or examiner or editor will say that this author, this student does not understand about post-hoc power, right? If you get a sample size same as you require, then no need to inform. If the sample size obtained was lower than sample size required, then you need to inform post-hoc power, right? Many researchers miss it. So that's why I mentioned here, right? Are you okay with this example? Are you okay?
Yes, Prof.
Okay. Ziwi, what time? How many minutes more I can take?
I think time is over.
Time is over.
Yeah. One question here.
Okay.
The study is related to alpha, beta, and gamma diversity of the bacterial community in the human gut. Many of the bacterial studies use a very small number of participants, especially in clinical settings, in measuring the temporal evaluation before and after intervention. May I know, is there any minimum number of participants required in this kind of study, at least have enough power to interpret the findings?
Okay. Look like before and after means it is the interventional study or observational study. Some studies before and after is observational. They just observe. Is this study an interventional study? You give something, or it is just an observational? The reason being, if it is interventional, of course we have to fulfill the requirement of power of 90%. If observational 80%, then sample size will be different. So can I ask you, it is interventional or is it observational?
It's both. Sometimes it's interventional studies, for example, to compare the autoimmune diseases. I mean, they see the effect of certain drug for autoimmune diseases in the gut. So the number of participants basically from 8 to 20 because the bacterial diversity itself is so large to interpret. So I'm not sure because sometimes they just put something like there is no sample size calculation for that kind of study. So that's why I'm asking, is there any minimum number for this?
Okay. As I mentioned, if you remember, in my second category, I mentioned some laboratory-based medicine, right? Also some bioequivalent study, as you know, you got the equivalent study, superior study, inferior study, and so and so. Some are guidelines, right? If there are guidelines, no need to calculate sample size, you can follow, but there must be established guideline, either national or international level. If not, you have to calculate sample size. And I'm aware that animal-based studies, laboratory-based medicine studies, majority are small sample size, right? Majority small sample size can fulfill the requirement. But again, if it is an interventional study, of course, relatively sample size should be bigger, right? Observation should be smaller. So you need to really differentiate. Is it an interventional? Is it an observational? Some studies, even laboratory medicine, some particularly it is intervention, put in something and look at it. Some are they just follow what happened and just observational. So based on that, power is different, sample size is different. Any more questions?
We have one question about calculation for cross-sectional study. That will be covered in the subsequent webinar on the sample size determination for observational studies.
Okay. Okay, that's so I won't touch it, right? For that.
Yeah, we will cover that for the next webinar. Okay.
Actually, Zimi, actually this 2 proportion now is clinical trial, actually, the clinical trial, but maybe because of time, I will demonstrate this proportion formula for clinical trials as well as observational studies. We'll do it next week, or next week.
Okay, no problem.
Okay.
Prof, shall we proceed with the consultation?
Yes, sure. But for our, first part, is there any more question?
Is there any more questions from the floor before we end this webinar? And one more question we have about the post-hoc power calculation.
Okay.
If we don't achieve the required minimum sample size or the required sample size plus the non-response, how do we actually calculate?
Okay. By right, we expect that there will be some missing data, there will be some withdrawal and loss to follow up. Because of that, we edit, right? So sample size calculation for post-hoc power is we calculate based on the original calculation. We don't go with the sample size after adding 10 or 20%. We don't go for it because our testable hypothesis is based on detectable difference and standard deviation. That is original definition just now, original calculation just now 121. We don't go for post-hoc power, putting expecting the number of after adding 10%. No, we don't go for it. We go by original number, right? So just now, if you look at it there, the thing that I put in for post-hoc power, I still remain the original delta, original sigma, original ratio. I keep it. I just change the number where 121 become 110. To respond the question, the post-hoc power is based on number you obtain, not towards the sample size after addition. towards the sample size, which is the original calculation based on parameters, right?
Another question is
Yes.
sample size calculation for case control study in clinical trials. Can we use the same software and shall we select t-test?
Say again, case control studies in clinical trials. Case control study is the observational study. Clinical trial, they are two different things. Can you read that again? Maybe talking about case and intervention and control. Zimi, can you read that again?
Maybe Nadia, you would like to ask the question?
You can ask me straight away, no problem.
Yeah, you can ask straight away the question.
Assalamualaikum, doctor. My study is case control study, and for sample size calculation, should I use the same software and should I select t-test?
Oh, okay. In case control studies is observational, where we are going to cover next week. Case control studies, basically they are proportion, right? So when proportion, as I mentioned here, proportion, you look at it here. Okay. Your question is, if for case control study, are we going to use t-test? Is it right? So t-test is for mean value. T-test for continuous variable outcome. We don't use t-test for case control studies. Case control studies are, if you remember my slides, case control studies outcome is what you call cases and control. Is it right? Cases and control, interested in exposure. So we used proportion, two proportion. Then you have to go to dichotomous here. Dichotomous, not here, t-test. Dichotomous.
Okay.
Right. Dichotomous. Okay. Any more? Any more questions? Zimi, any more questions?
No. So far, any more questions? No more questions in the chat box.
Okay. Wait, there's a cell culture. Sorry. There's something I saw it just now. To go for it. In cell culture, how to determine sample size? Okay. Cell culture again depends on outcome, right? If you have a culture and you are looking for the culture positive, negative kind of thing, and most probably it may not be trial. It may be if you had the culture positive, negative just result based on other factors. Your objective is, let's say, what are the factors affecting our culture, or maybe culture positive, negative, right? Compare with something else, for example. So it falls under what you call maybe a diagnostic test, right? Looking for the comparing between, let's say, blood culture and withdrawal test, or blood culture and urine stool culture, and something like that. So in that case, you can calculate sample size based on proportion. You can calculate, right? Depends on objective, right? And what you call if there's the association, maybe based on the Pearson chi-square test, then you can use the what you call sorry, not Pearson chi-square test, based on the Magnima test. Also, you can still use the related sample doing the two proportion. Depends on research question of blood culture, culture, right? So for culture, I think we can calculate, not like cell line, we can calculate, right?
Prof, is there any questions towards you? If there's no more, maybe we could proceed with the consultation.
No problem. You can continue consultation.
Yeah. All participants, thank you for joining the webinar. Please fill up the attendance form for jam latihan. Feel free to actually join our consultation.